Welcome to the Iconic Scholar Podcast. I'm your host, Andrea Kessler, co-founder of Scholarnetics 360. Get ready to journey beyond textbooks and learn from healthcare's brightest minds. Each episode is packed with insights and wisdom from industry leaders, uncovering the lessons and experiences that shape their careers. Join us to unlock the secrets to your successful career and discover the innovations shaping healthcare's future. Remember, while we're here to educate and inspire, we are not offering medical advice, just fun, educational, and authentic conversations. Okay, let's begin. Welcome to episode 3 of the Iconic Scholar. We're so excited that you joined us today. I'm Andrea Kessler, the host of the Iconic Scholar, and I have Eder Garavito here with me. Hi, Eder.
Hey, Andrea, how are you doing?
I'm doing pretty good. I really am excited to hear the news about the beta launch. You got any news for us?
Yeah. So we're getting closer to the beta launch. We are starting to recruit individuals who are really interested in being part of that beta launch. They're going to help us push this project to the finish line, going to let us know what works, what doesn't work. We really want their input. And not only that, special perks and benefits, highly discounted rates. They will have the ability to continue with highly discounted rates beyond the beta testing phase, and of course they'll get a head start within the platform, the Scholarnetics 360 platform, for when we do a full launch. We're also developing a referral system. We don't have the details completely tied yet, but it's going to look something like you refer somebody and you both get perks, whether it's discounts or benefits. So we'll start building that waiting list shortly after, but look out for emails and newsletters because seats are limited. We really do have limited seats, and we're going to have to shut the reservation of seats pretty soon before that launch happens, right around, I would say, end of April, mid-May of this year.
Awesome. And www.scholarnetics.com is where you want to go to sign up. We're also on LinkedIn, Instagram, Facebook, you name it. So awesome. We're so excited to get started. Today we have Dr. Michael Steiner. Special welcome to him. Michael is a doctor of physical therapy, and he is a concussion specialist at Twin Cities Orthopedics in Minnesota. His clinical practice has led him to developing the lead concussion program in the Twin Cities. That is awesome. Seeing a need to mentor and promote concussion training across all disciplines, Michael started the Concussion Spot education option. So it's a continuing education and training program that he's taking on the road so that he can support concussion, physical therapy, occupational therapy, just concussion, making it better treatment overall. So we're so excited to have you here, Michael. Welcome.
Thank you so much for having me. I appreciate it.
Yeah, and Mike, thanks for being here and taking time out of your busy schedule. And I just want to say for all of our listeners that Michael has been one of our very, very initial supporters for Scholarnetics 360. I mean, him and I have been communicating for a while. He's been asking a lot of great questions, and I just want to give you that props, Mike, because it is honestly people like you that remain interested, that keep us focused and keep us interested to kind of push us through the finish line, because we need that support, even if it's not support with creating, but the support of excitement and everything. So we really appreciate you.
Yeah, great.
Michael, first, I have to ask, how did you become a physical therapist? Why? What is your why for that?
Yeah, so I didn't know for a while that I wanted to become a PT. It wasn't until probably the summer before my senior year of undergrad that I actually put my mind on being a PT. So I had kind of short work to make sure I got all my prereqs. I had to take summer school to get all my prereqs ready so I could apply pretty short order. I was going between a bunch of different professions. I want to go to med school. I want to be, PT, OT. I was an exercise science major. So I'd want to go in like exercise physiology. I just didn't really know. After, thinking about it for a while and doing some shadowing, I decided on PT. And I think the reason I ended up deciding on it was really between that and med school. And from everyone I talked to with med school, with the really short patient appointments, like 8 to 15 minutes, and you're just running through patients kind of all the way throughout the day. I like the idea of having more time with my patients. And I love the idea of like an outpatient setting where it's it's kind of I can take that patient in front of me, and it's kind of like a jigsaw puzzle where they have random pain, maybe a non-specific diagnosis, and it was kind of that problem solving. So I think that's probably what led me to become a PT.
It's like detective work, isn't it?
It is, yeah.
I feel like most of us have like, hey, we might want to be a physician background, right? And then we become PTs. Not uncommon.
Right.
No, and I agree with you. Like the one thing about therapy, I'm an OT and PT, but the one thing I love is we get to spend more time with our patients. And I think that's something that we had Ricky Fernandez on our last podcast, and he's a burnout coach. But he was talking about how values are really important to maintain. And I know, like, even reading your bio, you have 4 children, and your family is really part of what you value. But I think as PTs, we do value how much time we get to spend with our patients. It's exciting. So fast forward, now you're a concussion specialist. You started your own con ed company, really, right? It's a really big deal. It's awesome. But how did you get there?
Yeah, tell us all about that.
Yeah, so it was interesting so we can back up to me being in PT school. Obviously, we hit a bunch of topics in PT school, but I always really resonated with vestibular PT. I don't know what it was. It always fascinated me, just on learning about the system and how it affects people, and how something so small can be, create so many big symptoms, and how it can be impactful in their lives so much. That just always fascinated me. And we had a great professor that really made it engaging when we were learning about that. And for some reason, I don't know, it came a little easier to me than some other subjects. So I gravitated toward that. Once I got out of school, I realized there's not a lot of people that really see a lot of that. So like coming out of school right away, I worked in a small, like, city-owned hospital in Minnesota, and I was already kind of one of the people we're looking for to see that. And I was just right out of school. So that just kind of fostering that development a little bit. And then I graduated, a little over 10 years ago. And, right about that time, it was just kind of a perfect storm in the concussion world where everything just kind of came to fruition. We had a lot of the stuff with, the Bennett Amalu stuff and the Mike Webster, and concussion became more of a mainstream topic. And, at that point in time, this isn't an operable condition. This is a rehabable functional injury. And, they really look to vestibular PTs to do this. And that's how I kind of got started. It was just kind of a perfect storm, and not a lot of people did it. And that's where I got started with it.
So tell me, like, your experience with concussion, though. Like, was there a program you could go to that would tell you exactly how to treat concussion? Because that was not my experience either. I see you shaking your head. I know our listeners can't see you shaking your head, but
Oh, he's shaking his head. Yeah.
No, there was nothing. This was me doing my own research, coming up with basically my own evidence-based program. And at that point in time, I was asked to kind of start from the ground up this concussion program for this city-owned hospital system. So I did that, and we got that going for a couple of years. And I was in charge of training some staff and getting that going. And then I moved on to TCO, and they're a really large company. It's in either the number 1 or second largest physician-owned practice in the country. And they're really big in orthopedics and sports medicine. But as far as, concussion, they didn't have really anything. So I came in, and then, there was basically myself, maybe one other therapist who doesn't work there anymore. And that was it that treated this. And now there's like over 300 therapists that work in this company. So we went from just myself and kind of pushing for this. And now we have over 23 therapists, last I looked, in 17 clinics that we've trained and that teach and kind of run this program. And we just coming up on a year now, we just opened a dedicated concussion clinic for the Metro, which is a pretty big deal. So yeah, a lot of growth in a pretty short period of time, but helping a lot of people, which is always fun.
Growth is good. And Andrew, I gotta ask this, Andrew, because I think I want to make sure I grasp this, because it's wild to me. Well, first I'll say this, I love neuro. I still love neuro. My neuro professor was so engaging. I wanted to do neuro. And then I treated neuro patients as a student, and I was like, there's no way. So good for you. So you graduated, you're a new grad. right? And let's be honest, after 10 years of practice, Mike, if you reflect back on your new grad days, we didn't know anything. We barely knew what we were doing, right? We think we know it all because we passed the licensure exam, but we don't really know what we don't know yet. So you're a new grad in a small rural hospital in Minnesota,
Mhm.
and you are tasked with developing a concussion program from the ground up and training people. Is that right?
Mhm. Mhm.
So it's obviously been a successful program you've developed, but I'm just curious, how did you feel when that was like brought on you at that moment? Because that's heavy.
Yeah, I mean, I guess I thought it was kind of exciting. I don't know, this is something that's always kind of fascinated me. So, and when you see other people maybe not as interested in taking that on and knowing that the impact that it can have and looking at starting the program to answer your question, probably why I didn't maybe think it was as heavy was so I had some other fellow PTs at that point in time, recent grads, and they worked actually downtown at like a large children's hospital. And what actually pushed me to do this was we had people coming from our community, which is about, 45 minutes or so out of the downtown area. They were commuting in to go to that clinic to get concussion care and then driving like an hour home. Right. And at that point in time, I thought, well, that's silly. Like, let's just make it here and offer it to them in town. So, I mean, that's really what pushed me, looking back, like it probably was maybe maybe a little naive going into it, but it all worked out okay.
I mean, I wouldn't say naive. I would say brave. Good for you. And just what you just said there about trying to help people not just beyond the concussion, but cut their commutes because they can't afford the commute or they don't have time. That is big on you, and I think
Mhm.
that speaks volumes to the type of clinician you are.
Thank you.
Improving access is, I agree. I echo that. We need to all be thinking that way. And it's interesting. You mentioned like that was really the driving force was to improve access. And look where it's led you, right? Like you're changing a lot of communities, especially in Minnesota, because I did a lot of traveling up there as a DCE. And I know it's like few and far between, like a lot of the region up there for hospitals or even access to anything. So tell me about how your program is structured. So you said it's face to face, not online.
Correct. Yeah, that's what I'm doing now. I'm not opposed to doing some online to help improve some access to that. But personally, I feel like when we're going through something that can be delicate, like a concussion, it can be confusing. Sometimes I feel like that's hard to convey through a screen, where I feel you get a little more depth of knowledge, a little more subtle understanding if you can have someone guiding you in person. And especially if it's a pre recorded on demand, I don't feel like you can ask those subtle, secondary, tertiary questions that will lead you to a little deeper understanding that really lets that light bulb click. So I prefer to do it in person. I feel like I can get my message across a little more. And I feel like I get better outcomes that way, but I'm definitely not opposed to the other.
No, that's great. Sounds like you really are in tune with your learners. And that's really important to you that they are learning what you're teaching them. And concussion is complex. It's not straightforward.
No, I'll be honest. I've been practicing for 10 years and I don't know how to treat a concussion, Mike. Like, no idea, to be honest. I can probably not even diagnose it.
I bet you can.
Don't bet against it, but let's hope I can.
So thinking a little bit now about your practice and if anybody's listening, they're interested in learning more concussion, like the adders that are listening out there and they're thinking, I don't know where to start. You know, what are some tips you would have for them, especially if they can't come to Minnesota for a training? Where would be some resources that you would guide them towards?
I would say the resources I would do is just looking at these international consensus statements. So the last one was done in Amsterdam. This was specifically on sport related concussion, but they do them about every 4 years and they compile all the new research that's happened over that time. And they put out their guidelines, as I'm sure you're aware of this. So I feel like if you're looking at that, that's a really good spot to start. Another good kind of basic informative is that has some training. It's just like impact training, not the actual impact program, but they have some good basic on-demand education as far as foundations on concussion. And then actually my website. So if you go on my website, which we'll put in the show notes, I'm sure, but I have a store on there. So you click on my concussion spot store and all my resources are free. I want everyone to have access to those. We've taken the most updated return to play protocol for concussion. So this is athletic trainers and PTs that work in that space or clinic. And we've updated them to the new international guidelines. And with those, they're all sport specific. So they kind of take out the guesswork of what activities are considered at what stage of rehab. So we have about over 35 sport specific return to play protocols on position. So it kind of takes some of that guesswork out. And then also there's just a lot of those clinic tools that you would use for PT, exertion testing, maybe some patient handouts in regards to like sleep hygiene. I know you're big with like lifestyle medicine, like sleep is really big for concussion, light aerobic exercise guidelines. Those are these patient handouts you would do, as well as the testing forms that you would do for exertion testing, so on and so forth. All those are right there. I use them in my courses as a central database for people to go, but anyone can access those. So I think that's really helpful in just setting your clinic or setting your practice up with the simple tools so you can be successful.
I love that, Mike. And we will put it in the show notes, but let's be real, some people won't read them. So yeah, please, what's the website? Give us the address and everything and how people can find you.
Yeah. So my website is concussionspot.education.com. Yep. So, or you can obviously type into Google, Michael Steiner, concussion spot education should pop up, and it'll navigate through on the basics of what a concussion is, as far as, what it is, what are the red flags that you're looking for that you're going to be referring out there, that is something that's more serious than a concussion. And it goes through all the courses that I'm going to have. And then I put up a blog. I try to put up a blog post every week on different evidence-based topics around concussion. And then we have the resources that we just talked about.
I really enjoy your blog. I read the one. I think you posted it today.
Are you a lurker? Are you a lurker, Andrea?
No, but it came up. Somehow it came up, I think, in my email. I must somehow have connected with you, Michael. Or did you post it on LinkedIn, maybe?
Well, I did send out an email to a bunch of people, but maybe you were in that group.
I don't know. Somehow I read it today. It was really good.
It's your Amazon Alexa.
Yeah, I know. Yeah. So my latest one, I just put on there the link between BPPV, or positional vertigo for those of you who aren't aware, and it's linked with concussion, how it has increased incidence. And the interesting part is BPPV is really easily treatable, but it's really, really frequently missed with concussion. And it significantly pushes out the recovery time out to, I want to say it was almost 19 weeks was the average of people before they figured out it was that. And that's something we can treat typically in a visit or two, and how that prolongs recovery somewhat. So just these little tidbits can really streamline the recovery process.
Yeah, I really appreciated the BPPV and concussion connection, because I had somebody that happened to me. I did not venture down the path of BPPV at all, and just was going strictly concussion treatment, right? And I think I was 3 weeks in. It was somebody who had fallen from a horse. And sure enough, I was like, wow, look at the rotational nystagmus. What is that? Looking, as she laid down, and I'm like, oh, we got to check for this. And sure enough, it was BPPV. So I appreciated that blog quite a bit, because that was like, once you figure it out, you're more aware next time. That's
100%.
the one. That's how I learned how to treat concussion. It was all by trial and error, slapping a pulse ox on somebody and seeing their heart rate going up and down with just, minimal movement. Right. That's curious. Could that be exertional?
Yeah.
So I think that teasing out the pieces of the puzzle and no patient's the same is something that's really cool. And one course I took was, her name's Mary Kuar. She's an occupational therapist who works with pediatric vestibular dysfunction, but she brought a functional optometrist with her.
Yes.
And holy cow, like learning. So then I started going to the athletic trainers and all these other speech therapists, right? And saying, hey, I want to learn what you do so I know when to send people to you so they can get faster or better faster.
Yeah.
And I think that for me, the interprofessional aspect of concussion treatment is huge for somebody's recovery. What 100%. Are your thoughts on that?
Yeah. Funny you bring up optometry. So like, once I was at TCO and we're growing the program, obviously I was not as experienced then as I am now. But just what you said, you're doing trial and error, and there's not as many resources on this. You're kind of building the plane as you go a little bit. And I just noticed that when I had patients that had a lot of ocular deficits, I was just really struggling with those patients. And I felt like at this point in time, I already went to vestibular certification courses. I went to some concussion ones, but no one really talks. They talk about vestibular, but they don't do a good job of differentiating that ocular aspect. So, and this is all, and I think PTs as a whole, we still really fail at this. So I found myself going to optometry conferences and sitting next to optometrists and taking those kinds of courses to gain a little better understanding of this. And as soon as I don't even have a wealth of knowledge there, I'd love to have a lot more. And I'm still working on that. But just to gain a little more insight into that, where everything is not functioning binocular, and we pull back to a monocular and get a better understanding of accommodation and not just pushing convergence all the time and going down that road, my results significantly improved. And that's one thing that if I had to say that I see most PTs make a mistake in, is that they don't look at things in a monocular world, is that they just function binocularly and their patients struggle and struggle and struggle. And once you pull that back and you start to make sure both eyes get tied up, we see a lot more improvement.
Headaches, right?
Yeah.
Treating a patient for neck pain, start talking to her. She gets headaches, history of headaches for 4 years.
Mm-hmm.
4 years? Yeah. Do you like reading? No, I hate to read. I used to love to read. Tell me about what happened 4 years ago. Well, I was in a car accident. Unhealed concussion, there's ocular issues. You'd start looking at all these pieces.
Yeah.
I mean, and I've also seen people who've healed, but then some of these problems creep back in. Like, again, it goes back, there's nothing really published about that, but at the same time, those are just some of the things I've seen. What are a few of like those, I would call them Michaelisms, if you will, like those types of, this is something I see. It's not necessarily published information but it's something that I've seen consistently with concussion. Is there anything like that you've seen?
The one thing that I tend to focus on is if I'm treating a concussion right and everything's coming together, typically we see pretty quick progress in the majority of patients. I would say well over 80% of them. If we are struggling to make progress in 3 to 4 visits, usually I need to get some help. I'm not one to sit around and wait with that patient for a long time, because I found that typically if I'm not seeing improvement in 3 or 4 visits, I'm not seeing improvement at 3 months with a lot of those patients if I'm not getting some help. And one metric that I find consistently, especially when they have these frontal headaches and some ocular motor deficits, is if you measure not just convergence, but a monocular accommodation. So you're taking basically a one eye measurement of where they lose clarity. If I find that there's an abnormality there and I'm not seeing significant improvement in 3 visits, that's an automatic referral to optometry for me. And I find as soon as I clean that up, a lot of times we're seeing tons of improvement.
It's funny you say that, because I had a patient at the hospital recently I was covering. Didn't do the evaluation, but I'm treating this patient totally. I'm like, this is an optometry situation.
Mm-hmm.
So I say to the gentleman, okay, so the therapist I was covering for is not concussion specialist. So I say to the patient, I'm going to make a referral to your primary care doctor that you visit an optometrist who can look at your eyes and see if you might need special glasses. And he says, oh, yeah, I'm going next week to get those glasses. Oh, okay. Because I'm thinking we really need those glasses to see any improvement. But then I said to him, well, did you tell the physical therapist that when you were here last time for your evaluation? And he said, no, but he didn't ask. So I think that like those questions, that goes back to at what point, like, do we as therapists need to say, we need to maybe have more training before we treat a patient like that? Like, is there any pieces of really the concussion evaluation for somebody who doesn't typically treat vestibular or concussion that you think would be beneficial for them to have as a resource on hand? Like you have all these resources. Is there anything you would say? Do you have an evaluation? Do you have questions?
I just put my general eval templates. That's a download on my website. But I like to think about it as physical therapists. We treat a lot of musculoskeletal issues. We're really typically pretty common or comfortable with dealing with like a goniometer, right? Well, when I'm treating concussion patients, are you familiar with like an accommodation rule? Is that something you use? Yeah.
Mm-hmm.
I treat that just like I would a goniometer with anything else. Like I want to make sure I'm getting those levels as far as accommodation and convergence back to normal limits. So I feel like making sure they feel comfortable taking those ocular measurements, just like you would for a goniometer. I think that's like a concussion 101. And in all honesty, a lot of people don't treat that or don't teach that.
Yeah, and I think it's the measurement piece people might not be as comfortable with, but I think that is so important to impress upon therapists that have and especially in a rural community where you might be the only physical therapist and you have to treat this patient.
I mean, that's kind of like where you live, Andrea. Like you're the only one in that area that treats these specialty sort of conditions, right?
Yeah, and I think it goes back to what you said, Michael, like it's an access issue, right? And
Mm-hmm.
you want to do the best for your patients, but at the same time, that's where like if you were a mentor for Scholarnetics, I could call you and say, I haven't treated concussion before. Can you help me?
Right.
That's really the connection piece that we need. I think therapists to feel comfortable even reaching out to somebody.
Right. And I tend to do that with all my courses too. Is I have several people that have taken my courses and they run into a roadblock. It's an open door policy, right?
Awesome.
You go ahead and you email me, you call me, and I go through cases all the time, probably on a weekly basis, if it's within my organization or it's from people from rural Minnesota or out of state that have taken one of my courses and they want to go through something like that. I do that all the time.
Good
Ed,
for you.
do you know Dr. Daniel from Duke?
No, not familiar with him.
Yeah, no, I mean, look, I don't feel comfortable with a goniometer, Andrea. I haven't used one in 11 years, so
No, but
I don't know, Neuro.
He taught my first vestibular course, that Con Ed course that I went to.
Oh, gotcha. Yeah, no, I'm not familiar with them. But to your point about the connecting, let's use a real example, something that is real for any listener here, because I just confessed earlier. I mean, I don't know how to. I'm serious. Like I probably don't know how to treat a concussion, and I have not used a goniometer in my professional life. Now, to be clear, I've been treating cardiac and pulmonary patients, so it's a different world. But let's say that I'm treating one of my patients, right? And they come in with these symptoms. I'll be honest, like I'm going to go on Google. I don't know what to do, right? Like, but like if I can connect with Michael or somebody like you to just, hey, like I have a patient that has these, signs, these symptoms. Is it what I think it is, or what is it, and how can I treat it? Because a lot of PT things, and there are many that are not, but a lot of PT interventions are like riding a bike. We just need a little guidance. Now, I understand there are a lot that are sensitive, but you could probably help a lot of people that don't have access to this knowledge. And you're already doing it. And that's just amazing.
Yeah, it's fun. Yeah, and it kind of comes back to the reason why I chose PT in the first place, right? It's kind of like that detective, that problem solving. You get a little bit of addicted to that problem solving, right? Where if you can solve it and become successful, like you get there's some excitement to that. So I like that.
Are you working with ENTs and neuropsychologists? And
I don't really work directly with ENTs. Well, I'll get some referrals from them to treat. But we do work with neuropsychology. I don't find that I refer a ton of patients there, but yeah, there's definitely patients there that we refer to neuropsych.
so interesting because I think it's regional with different people who are involved in that concussion team. So as far as your programs are set up, I know physical therapists are a focus for who you're reaching out to, but other professions that could take your courses, occupational therapists, speech
Athletic trainers.
athletic trainers.
Yeah. Yeah, I would say I haven't had speech therapists come yet, but PT, PTA, athletic trainer, OT, chiropractor, those are the ones that I typically see the most. I mean, depends on your involvement in the clinic, but a PA, nurse practitioner or something like that, you're definitely going to get some value there too. But really probably geared more towards those rehab specialists that we're going to have more time. I mean, that's what a lot of my course goes into, is that deeper dive. And like, how do we, I mean, we got all these buckets, right? You know, we might have someone who has all six of those disciplines involved. We might have one that only has one or two. So like, how do we tease that out? And once you can tease that out, and maybe it's just because I've been doing it for a while, like it gets super simple. But right when you're looking at it, it can look really hairy. But as soon as, you know, I feel like I've put together a pretty streamlined assessment that by the end of that session, about 80% of those deficits, we should have a good idea of what's driving that. And then we just got to stress each one. And I would say if I had a new therapist, the one thing that I tend to tell them, and new therapists, I feel like don't do this enough, especially with concussion, is we can't be afraid to make our patient symptomatic, with a little caveat. And I feel like we don't want to just make them symptomatic generally, but if I know what I'm stressing and I can tease up their symptoms and bring them back down, then I know what I need to do to make them better from that aspect. And I just need to figure out all those different pieces. And then I know what pulley to pull, and then we can get some good neuroplasticity and we can make some progress.
He does sound like a detective, doesn't he?
That's awesome advice.
It's incredible advice. It really is, because a lot of times we are afraid. Heck, in my world with cardiac patients, a lot of times when my students think that because a patient has AFib, they're literally going to die. No, we have to do these things. Different worlds, but still similar. I love that analogy, and it's so good.
Really is. Michael, I'm so glad you were able to join us today. I could talk to you all day. I really could. I love talking to you. I'm going to look at your programs. I'm going to definitely recommend people to take your courses, because I think especially the open door policy, I wish more Con Ed programs would offer that. And that really needs to be part of the learning experience is, okay, I go home, I practice in my clinic, I'm still confused now. What?
And I find that a lot of people don't utilize it, but I think it could definitely be utilized more. But the ones that do, I feel like we can kind of take that fog or that curtain away for them and allow that to click a little deeper.
Why do you think people are hesitant to reach out to you? Do you think it's because they get it, or do you think that there's a fear of admitting that they're confused or they might not understand something? What are your thoughts on that?
I think for a lot of people, it's more of they don't want to admit that maybe they don't have it 100%, which, man, I don't have it 100%. I mean, if we think we know everything about concussion right now, I think we're fooling ourselves. We are just at the starting line. We've made so much progress in the last decade. Just think what the next decade is going to be. So, I mean, for us to think we know it all, like, we are fooling ourselves. So I know when I came out of school, sometimes that's hard to admit it initially. But as soon as you get by that barrier, there's a wealth of knowledge that you're only going to continue to grow.
I think you just became Andrea's and my best friend. That is a message we're really trying to push, because not only is it important for growth, right? Like you've seen, Mike, you reflecting, hey, look, I've grown this much because I have admitted my errors and I've fixed them and I've learned from them. Sometimes individuals who are not flexible and they're not open to admitting their errors can injure patients. And that is, that is just something that does happen, and it happens in the healthcare profession. So we need to sort of back up and destigmatize. I don't know if that's a word or not, but I'm using it.
I think it is.
Yeah, well, we're gonna use it anyways, right? But we gotta just destigmatize being wrong and admitting that we need help. And it isn't like you mentioned, Mike. You graduate from PT school and it's hard because you just learned so much and you pass your board exam. It's hard to say like I don't know anything, especially as a new grad, because you just got your job. But I think just being able to be vulnerable and open yourself to learning more and not setting up that barrier. Not only would you be more successful, I think you'll enjoy your career a lot more.
Mm-hmm.
Yeah. And even if you're 45, 50 years old.
Yeah, always.
Start something new. Learn something new. Don't be afraid. That's how things grow and develop, and you move in new directions. It's exciting. I think that's part of burnout too, is that sometimes we do get stuck in that, just this is the hamster wheel, if you will. And we need to move out of the hamster wheel and open up our options and learn new things. And I think that concussion is a great place for people to move into that space, for sure.
Yeah, I'd have to agree.
Yeah, I don't think Michael's ever been in a hamster wheel, to be honest. like at all.
Not with concussion.
Yeah, ever, right?
Well, I want to thank you again for joining us. I have to ask you a couple questions before we go. Can you define what a mentor is for you?
Yeah, so I've had a few. I mean, how they've helped me in the past. It's always been kind of a one-on-one relationship, but just someone that you feel comfortable going to and someone you could lean on to kind of help you through kind of a decision-making process, kind of help me grow. So, there's a couple of my professors that I still have a tendency to go back to. And all those mentors are just really accepting as far as, any questions you have. They may not have the answer, but doing the best to kind of help you through any kind of questions or struggle with the situation you have. I feel like that's a mentor, just being open and doing the best you can to help that person, if it's you or guiding them to the answer someplace else.
I really like that. You kind of answered my second question. It was going to be, how do you like to be mentored? And I think that what I heard so far, and I'd love to hear if you have more thoughts, but you like to be guided, not told how to do something. You want to find it out for yourself. I got that right?
Yeah. And if they do tell me, they're, I still have the freedom to, evolve that, right? But that mentor doesn't have judgment that if I don't do it exactly as they say, it's not there, right? So I think that openness and that not judgment and just the overall willingness to help rather than just tell you how to do it, I think that's key.
Yeah, judgment is something also we're trying to kind of push with what we're doing. But aside from promoting what we're doing, I think that we need to continue to shift away from these models and expectations that if somebody has some sort of a professional or academic hold over you, right, your grades or your career, like that's not going to be a true mentorship experience. It can be a good relationship and a good educational one. But man, you just hit the nail on the head with that one. Just a mentor to me, just like you, I want to be able to just tell them anything and not feel judged, not feel like I'm not smart enough or anything. And that's a huge aspect in guiding somebody to grow.
Yeah. And I think also being open as a mentor, you hope that they'll be open to if you have a different view, right? Like, what's the saying? Evidence-based practice. That's the big push. And everybody should, this is the best way to practice to treat this condition, right? And we'll all get better results if we all practice the same way. But really, if you go to 10 different therapists, you'll get 10 different treatments. Who's to say that that person's certain condition and all the pieces that go together to help them to function, maybe that was a good match for them. That was the best treatment for them. So I think from a mentor perspective, you also want somebody who's going to be open-minded, along with that non-judgmental piece. It's really important.
Yeah, and we know that, evidence-based practice is very, very good. And we know that if I apply these principles, I know I'm going to typically get a good outcome. But the other half to that, if you're looking at chronic pain or just other patients in general, kind of that therapeutic connection, therapeutic alliance, however you want to say it. If I can have that, maybe mix in a little placebo and give them the right treatment, like you're going to knock that out of the park 9 times out of 10. So I think pairing all those things together along with the best evidence-based approach is typically where we get the best outcome.
I love that. Another good piece of advice. Michaelisms. That's what I'm calling them. You have these great tips. Well, Michael, thank you so much for joining us. It was such a pleasure talking to you. I'm hoping that we can maybe reconnect in the future so we can talk more
Absolutely.
about how things are going with you. And we would love if you were a mentor for Scholernetics 360, because you're amazing. And I'm sure our listeners would love to have a conversation with you if they could. So please join Scholernetics 360.
Right. It was like we're begging now because he's going to be amazing.
But he's an amazing therapist.
He's an amazing everything, right? Yeah, thanks so much, Mike, for joining us. I don't do concussions or neuro, but it has been just so eye-opening to really listen to all this, because you have so many important things to say. So just one more time before we go to drop your website for people that are listening. We'll put it in the show notes, but some people don't read those.
Yeah. So you can find me and all my resources and any courses that I'm teaching at concussionspot education.com. So concussionspot education.com.
Thank you, Michael.
Yeah, thank you very much. I appreciate you having me. It's been fun. I mean, I could talk about this for a couple of days, but I know we just got short time, so it was a blast. Thank you very much.
We'll have Andrea and you do a part 2. How's that?
That sounds great.
Absolutely. Thank you for joining us on the Iconic Scholar podcast. If you enjoyed today's episode and want to continue the conversation, don't forget to connect with us on social media as @ScholarNetics360. Make sure to hit that subscribe button so you never miss an episode. And remember, always consult with a healthcare professional for medical advice. Until next time,